Good morning, everyone. We are right at 9 a.m. And I appreciate you joining us for this session this morning on artificial intelligence in healthcare. And obviously, this is an extremely broad topic, and there's no way we could cover everything under the sun in 90 minutes. So I'm Kate Harback. I'm the CEO at the Institute of Health Economics, which is based here in Edmonton. And I've put together a panel that brings a diversity of perspectives, very broad, so that we can make the most of this 90 minutes and get some different takes on this. First, I'm going to hand it over for an orienting slide briefing to Joey from Alberta Machine Intelligence Institute. He has a broad ecosystem perspective and supports innovators and thinks across the system. We're also joined by Glen, who is from our shared services organization in Alberta, who is in charge of a lot of the kind of data infrastructure and thinking on that will enable future applications. We've also got Myrna, who is an entrepreneur and has a company, RUNWITHIT Synthetics, that does amazing simulations to support decision makers. And there is a lot of regional economic perspective in her work, so relevant to this conference and organizations represented here beyond interest in health, but also really important to health perspectives. Also, Paula, who works with Cancer Care Alberta. I'll let all of the folks do their in-depth own introduction with the job titles, but just giving you some sense of the breadth of experience represented by this panel. And then Neesh from the university, who, in addition to a living lab perspective, which is where we can build trust and learn how things work, also is training the future workforce that will be using AI. So with that, I'm going to hand it over to Joey, who will get right into it with the presentation, assuming the slides are good now. Yes, I see slides. Awesome.
All right, good morning, everyone. Thanks, Kate. So I'm here to spend the next 10 to 15 minutes just to give you a bit of an overview before we kind of jump into the panel, just to set some context and just provide you some information that would help you kind of get the most out of the panel coming up. So just a little bit about AMI. So AMI is one of the three AI institutes in Canada, the other being in Montreal and another one in Toronto. And there's two big things we do. We support AI researchers across Canada, through our CFAR Chair program, but also we help organizations deploy and build AI for their businesses and help them along their AI journey. And through kind of this experience and through our work, we've kind of seen some themes and trends we'd like to share with the group here around healthcare. So really quick outline. So in terms of just, we're gonna just set the stage with the system in Canada. I know there's some people from the States here, so getting them accustomed to what it looks like in Canada in terms of healthcare and what it looks like specifically in Alberta, and then going into just the themes and trends we've kind of been seeing in the industry, and then just moving right into our panel discussion after that. So just to set the stage and get the background here. So in Canada, there's 13 systems because federally universal healthcare is mandated as a federal mandate, but the funds are transferred to each province or territory to deliver those healthcare services. We call it a public payer model. So hospital and physician services are quote unquote free at the point of service. So no money is being exchanged when a patient receives healthcare services. But most physicians are actually independent contractors who bill the government, after they deliver the service. Sometimes at the end of their day, bill the government in that way. But they're not necessarily government employees. And I'd say most because that's not every situation, but most situations. What's not universally covered? So it gets tricky because it does change over the years, but majority of prescription drugs, a variety of dental services, vision, fall outside this universal plan for working age adults. Generally, working age adults have private insurance plans that cover a lot of these services or medications per se, but there are targeted public programs that support seniors, children, low-income families, and that differs across all the provinces. So all the provinces have their own programs that support these groups. Specifically in Alberta, so with a population of about 5 million and a $34 billion healthcare budget, these funds come from the federal government, support the care that's delivered through the province. And something unique to Alberta is that our hospital system, our hospital care is delivered as a single provincial system. Sometimes in other provinces, you see a variety of kind of like groups of systems that kind of work kind of not in silo, but essentially work as a group. But there's a variety of these groups throughout the province, and they deliver hospital services based on their goals there. But in Alberta, it's just one system, so that provides a lot of benefit in terms of just streamlining administrative tasks and other kind of operative type things. We have like one lab provider, for example, one emergency medical service, and one EMR system across all the hospital systems, which leads to a lot of benefit in terms of sharing information across different cities and different areas of the province. Physicians are still independent in the system here. So family doctors and many specialists are, essentially private businesses. They're contractors. They bill the government for their services, like I said in the previous slide. But something to note here, and we might come across in our panel, is that primary care is probably the most decentralized part of the system. Because if you think about it, family physicians here are primary care providers. It's their own little small business, so they figure out their own staffing, their own EMR needs, and they're kind of their own individual units. And you have all of these different units across the province, so you can kind of tell it can get complicated with so many different small businesses in that way. In terms of data, so data-wise, one of the big benefits of this model in Canada and also this province is that we just have all this data in terms of there's fewer sources that the data sits in. That leads to a lot of benefits. So in Alberta specifically, we have something called Netcare. It's this electronic health record that a pharmacist in Edmonton can see what someone's hospital stay looked like in Calgary through this kind of shared record here. It doesn't have every single thing, but it has a lot of things that really helps make care really comprehensive, or just not necessarily comprehensive, but easy, a lot less barriers or challenges when you're moving across different systems or services. Hospitals, one unified system here that allows a lot of data to be gathered in one system, leading to a lot of benefit. But again, I point out primary care because of the structure of primary care. It's these little individual businesses. They have their individual EMRs, and those EMRs don't necessarily talk to one another. So if I go to one clinic down the street, receive a service, and I go to another clinic, a block down, they might not necessarily know what happened in that other office because those systems aren't connected in the primary care setting. So I'll talk to a little bit about some of the challenges there. So hopefully that kind of sets the stage in terms of just where things are at here. And in terms of themes, trends, and just like some of the products. So something we're going to hear a lot about now and probably for a long time is this challenge around interoperability. So just for those unfamiliar with the term, the definition, it just refers to the access, integration, and the use of electronic medical data across various systems. There's a lot of benefits if we solve this type of issue, because right now about 70% of this data doesn't move between providers in Canada, or even kind of like I mentioned in my example, like even within the province or within the city. And if this could be improved or even solved, we could save as much as over $2 billion a year just around this topic alone. Legislation is being proposed, and it's still in progress, but there's a lot of different people and groups trying to tackle this challenge. And why exactly does this challenge exist? When we kind of look at some of the literature, just like some of the resources here, essentially the constitutional structure of how healthcare is delivered in Canada causes some friction here, because federally government can do certain things in the healthcare space, but at the end of the day, the provinces have that final say. And it can be sometimes hard to coordinate like all 13 provinces and territories along one thing. In previous years too, with say for EMRs, for example, provinces have opted into this voluntary idea of there's these voluntary standards that you could meet for best practices in terms of maybe structuring your data or making sure certain systems talk to one another. But because of this voluntary approach, there's not necessarily a lot of business incentive to follow these standards. Because of this third point here, this data blocking idea, in that it's tough. If you think about it in a business sense, it's not necessarily you don't want to lower switching costs if you're kind of a particular business owner, because that could lead to more people leaving depending on what you're delivering there. So it can cause a little bit of friction when you're thinking about the incentives and kind of maybe the overall goal of creating less interoperability challenges. So really, the bottom line here, this gap is there, and it's probably going to be here for a little bit as we sort through a lot of these problems. I'll only list 3 problems. There's a whole set of other problems to kind of think about, and again, we're going to hear a lot about this now and for the next few years here. Another thing we've kind of noticed is that the idea of implementation, this gap between experimentation and implementation, is still really big. There's a lot of news. There's a lot of hype, I guess, around using AI in the healthcare system and how all the efficiency gains, all the big improvements, and I think the hype is backed by a lot of great technology, but a lot of the issue, and this survey from Deloitte found that majority of executives expect a lot of benefits, whether it be revenue, margins, lower operating costs, to happen in this next year. But when we actually survey those, deploying these systems or implementing these systems, there's here 30% of surveyed health systems report generative AI operating within certain areas of the organization, but really, when we're looking across the whole organization, only 2% actually have deployed it across like that whole org. And there's even some literature just even supporting around that technology. Really, now we have great technology, and it's not necessarily the technology holding us back, but it's all that stuff around it. That's like all that change management. It's all the getting people on board. It's all everyone agreeing to kind of implementing the technologies here. And again, just kind of reiterating some of the reasons why this data readiness bit, some of the organizations we work with, it's just really challenging when you talk to them, getting health data, bringing it together, how messy this type of data can be, but also just all the legislation challenges around it in terms of just privacy, sharing this data, all really important concepts, but it's something that is everyone's just navigating right now because there's just such great technology, but we're just trying to play catch up with getting that data ready for the technology. The governance bit, like I said, it's just having all these different jurisdictions. As a business owner, if you're trying to implement some sort of EMR system in one province and you want to spread it across Canada, right now you'd likely have to create maybe 13 different versions of your EMR system, because all the different legislations and the policies and the things you have to kind of be aware of as you're implementing. And it's just some of the things that make it, less attractive. But hopefully things that will improve over time here. Bottom line, a lot of expectations are high, and I think it's warranted, but these barriers with implementation is just a big problem to address. And really, organizational readiness, a lot of great things happening in this regard right now and in the future, but something you'll hear just in the space a lot over and over again, and that would be just something to keep in mind. Drug discovery, this is something that people have been talking about for a lot of years as well. So, the theory for those who haven't been aware is that AI would just significantly shorten drug discovery time. We could find drugs faster, get them to market faster, and we could have new therapies saving lives just through the use of AI here. Save money and whatnot. So as of right now, 2026, that theory essentially gets tested. So a lot of the drugs have been using AI to be discovered, and a lot of these candidates are currently in like the clinical. There's like these clinical phases that a drug needs to go through. A lot of them are in those trials right now. And essentially, at this moment, there is no drug that's FDA approved that has been discovered by AI just of yet. There is one. There's one for pulmonary fibrosis. It's currently in phase 3, and it looks actually quite promising. And I believe that's probably going to be the first one. And that's, I think, if all things go well, you could hear about it maybe this year or next year. So it is coming, and it looks very, very promising. But some of the bottom lines here, if you think about it 360, is that drug discovery has been accelerated. More drugs, more molecules are being discovered, but there's bottlenecks in the rest of that kind of chain there. So we might find molecules faster, but things like phase 2 clinical trial, phase 3 clinical trial, you still hit those bottlenecks with patient recruitment, just the whole getting that drug to market. There's still challenges, and that's where a lot of the venture capital is slowly flowing to. A lot of great systems in drug discovery, but a lot of money is being flowed into the speeding up or improving those other parts of the chain of getting a drug to market. So a kind of a trend you'll probably hear about and see in the next few years. Something in Amy, and a very similar trend or theme you might see in other places is these models that help some sort of process. So here, there's Amy scientists teamed up with a rheumatologist to kind of tackle this problem about sorting through referrals. So, you have a specialist who gets a referral from a primary care practitioner. And if you think about it, this specialist has to sort through referrals, but also see patients. So you kind of have to sacrifice one or the other to do one. And because of that, you see these long wait lists happen. This Amy researcher created this triage model that essentially helps speed up this referral sorting process. Specialists could kind of keep seeing patients while this model would help them prioritize and bring those more severe patient cases up to the front of the line without as much manpower needed. So you can kind of see here this idea of speeding up a process or making things more efficient can be applied to a lot of specialties and a lot of different areas in healthcare. And it's one of the things you're likely going to see in the next years as a lot of these technologies are developing. And this year alone, I just kind of listed a bunch of different points from all the big different labs: OpenAI, Anthropic, Google, Amazon, and even Epic. A lot of different things they've released this year, from models to different tool sets and whatnot. And even Myrna here, who runs RunWitHit Synthetics, released their own set of health attributions to their own synthetic population product that we'll hear about in the panel here. So a lot of cool things coming up. And it's just a little bit of a snapshot in terms of what I'm seeing.
Okay. Thank you. Thank you for that, Joey. Just to orient to some of the things on the go and characteristics of our environment with respect to data and the healthcare system, to let the other panelists introduce themselves and start to characterize their perspective before we go into big questions. I'm going to let each of them go down the line and introduce themselves, and with name, organization, that context, if you'd also like to tell the audience one thing you'd like them to understand about health data as an ingredient to AI applications.
Thank you, and good morning. So my name is Neesh Pannu. I am a physician, a scientist at the University of Alberta here in Edmonton. I'm also the Vice Dean of Clinical Research at the Faculty of Medicine and Dentistry here. And I also lead the AI and Health Hub, which is a university initiative specifically designed to address issues related to AI in healthcare. So what I want people to know, I guess the availability of clean population-based data is really critical to the development of ethical, unbiased AI models. And so that's what I would say to start the conversation. Okay.
Morning, everybody. My name is Paula Robson. I work in Cancer Care Alberta. Cancer Care Alberta is the provincial health corporation that's charged with delivering treatment and care to everybody in Alberta who's diagnosed with cancer. We do that through 2 tertiary cancer centres, one in Edmonton, one in Calgary, 4 regionals, which is one in Lethbridge, one in Medicine Hat, one in Red Deer, one in Grand Prairie, and 11 community cancer centres dotted around the province, trying to deliver care as close to home as possible for people diagnosed with cancer. What I want you to know is that if we were sitting here in 2006, I would be telling you that 13,000 people in Alberta were diagnosed with cancer each year. If we were sitting here in 2016, that would be up to 18,000. Today, it's about 24, 25,000 and projecting for 35,000 in the next 10 years. So that is not because cancer rates are changing, but it's because our population is aging, our population is growing. But the upside of that is people are living longer after a cancer diagnosis. They're living longer with a better quality of life because we have rapidly evolving treatment, we have rapidly evolving models of care. Now, all of that comes into a population where we're seeing more people living with cancer. But every interaction that those people have with the healthcare system generates a data point. Every single interaction. So if you start to think about that in the cancer system between 2010 and 2025, we have about 300,000 people diagnosed with cancer, multiple visits to the system, generating 14, 15 million data points that actually become a gold mine for AI machine learning. And what do we do with it? Well, what we're trying to do with it is to say how we deliver cancer care 10 years ago is not how we're going to deliver cancer care in the future. So we need to be getting smart with using our data and applying new models, strategic foresight, planning for the future, and thinking how we're going to be able to deliver care. Thank you.
Hi, my name is Myrna Bittner. Again, I'm CEO and co-founder of RUNWITHIT Synthetics. So we're a technology company that's 12 years now, based in Edmonton, but we have people across Canada. We worked extensively in the US over our past 12-year history, actually doing some health modeling, so right deep embedded in the critical infrastructure and energy systems during COVID. We were modeling populations and their response and the pathology and public health and epidemiology as that disease spread to inform everything from policies around sequestering staff in critical facilities, but also informing load purchasing by energy grid customers. So, we've spent a long time modeling populations. Synthetics is an interesting field because we take a convergence approach. So the research and data that we learn from place-based intelligence, we call it 6 dimensions, but the natural and built environments that we live in and the critical systems that operate around us, and the environment that we live in. But then we also create living systems. So whether those are our infrastructure, our housing, our transportation, our climate, and then we place populations in those systems. And those populations are never identified. So we have a different approach that overcomes a lot of the data barriers when it comes to surveillance data or privacy protected data. And this enables us to see populations and attribute populations given the latest research that's being done in health, but also what we know that exists far beyond a patient record. So 99% of your life is not incorporated into a patient record or that data, and yet that informs your compliance with therapeutics. It informs your experience, your environmental exposure, your ability to access healthcare. And so we work in a lot of populations and developing a lot of populations that don't exist in current healthcare data and the information that we need to bring to those patient files and kind of merge together or converge. And I guess what I would like you to know about artificial intelligence in healthcare is it's a big field. And there is many advancements taking many different and really unique and diverse approaches, right from the very operational or tactical or molecule discovery to enhancing the way information transverses across patient healthcare and access, to research that's being done and accelerated and advanced, but also into system design. Because while we're sitting here today under an air quality alert, we have done advanced modeling in this very region about wildfire PM 2.5, the economic impacts of it, the economic impacts of evacuations, of the vulnerability of houseless populations, et cetera. And so it's really important, I think, to see health in that larger context as well, and know that there's a significant role that health plays, no matter what room you're sitting in this conference, and that needs to be united, because health is one of the operational things that we're all striving for, whether we're managing energy or the economy or quantum. That's why we're here, is so that we can live healthy, sustainable lives.
Good morning. My name is Glen Shortt. I lead our data and digital health team at Health Shared Services. Health Shared Services, we're a corporation that provides, government-funded corporation that provides services to all the provincial health agencies and provincial health corporations. So it includes all the hospitals and I won't go into the long list of areas that we provide support to. My team specifically, again, includes data analytics, teams that manage the health information technology, and then the teams, we call them clinical informaticians. They're the ones that design clinical workflows in our EMR systems. They go to sites and work with clinicians to support adoption and training. So really at the coalface of where the data is collected, and I guess so it brings me to the thing I want you to know about AI is it really starts, and it's probably building a little on your comment. It really starts with the system design at the where clinicians are using the systems, the data definitions, making sure it's intuitive so people are using systems appropriately and effectively. There's a lot of hard work that goes into actually getting systems implemented, being used by clinicians. And again, that is what leads to quality data, which then leads to the models that can be built on top of it. But it really starts with that foundational design of systems.
Sure. Hello. Oh, yeah, perfect. So my name is Joyton, just like I mentioned in the presentation there. So I'm one of the project leads at AMI. So at AMI, I sit on a lot of client projects that help develop AI models and kind of bring them and deploy them into their systems. So my portfolio, I'm trained as a pharmacist. So taking my clinical lens and this technology lens and putting it into practice for clients. In terms of something that maybe to share with the group, it's just working in the health space. It's a slow process, but very rewarding, and you have to be in it for the long haul because of all the things you need to navigate around data and whatnot. So just I guess my point of view there.
Great, thank you, everyone. Oh, that was loud. Sorry. For a behavioral economics moment, I was wondering if my panelists could distribute the 3 microphones that find their way at the end across yourselves so I can hold the microphone the whole time. Thank you. Getting into questions. Our first question is about the regional AI ecosystem and how, in particular, how Alberta has done this, but also lessons for broader regions on what allows a region to translate AI research into better healthcare, successful companies, and sustainable economic growth? Acknowledging we'll have a breadth of perspectives there. Glen, do you want to start us off, maybe talking about our infrastructure? Joey set us up a little bit and talking about the Alberta advantage of having that unified EMR. Go ahead.
Yeah, I think from my perspective, having a very robust data infrastructure, and by that I mean like this collection of data assets that can be leveraged to build models on top of. So within Alberta, we have a very rich data asset. It's clinically rich. It's cross continuum. It's covers the range of population. It's high quality data, and that's due in part and maybe largely in part because we do have, as Joy mentioned, a single clinical information system we use across our hospitals and many other care settings as well. And that means that common data definitions are used when people are using the system. Common workflow, so it's generating really quality data. In addition to that, we also have I would call AI ready architecture, so that the governance is built in, again, the classification of the data, essentially, and enabling us to build data products on top of that, really rich data infrastructure. I think that's one thing that's really important. A couple of things I think that we've leveraged in Alberta. I think public-private partnerships. So working public health system, working with groups like AMI and other innovators with government, it sort of creates this compelling opportunity for again leveraging this really rich data asset. We have problems in healthcare, and so really good test beds for innovation. We have innovators who can move much more quickly than typically we can in the public sector. So I think that sort of creates a really good sort of mutually beneficial opportunity for innovation. And then finally, I think our provincial scale, again, as Joey mentioned in Alberta, because we really are like a fairly integrated system across the province, unlike other provinces where there's sort of pockets of hospitals. We are one large system. So in terms of getting bang for your investment, we can develop innovation and scale it across the province because, again, we use single systems, common workflows. So the ability to scale is probably much easier to do here, and that just leads to, I think, better sort of value for investment.
Thank you, Glen. I next wanted to move to Myrna. Same question, and obviously recognizing that in your work, you've characterized health as being part of the whole system that supports regional resiliency and prosperity, and very integrated, but not just that perspective, thinking about your perspective as an entrepreneur and having founded a company in Alberta. I'm wondering if you could comment about the nature of the ecosystem that led to RUNWITHIT Synthetics and how you've interacted with that.
Sure. So I think, yes, my experience is very different. We're still getting to know the provincial authorities. So we have more experience with the U.S. authorities than even in our home province. But for us, I think the ecosystem really involved that export relationship. So we have been engaged around the world, and that's something that as a Canadian company and a company from Alberta, you're highly encouraged to do, is to build that resilience. It also has given us a very unique perspective because we have encountered many different approaches to artificial intelligence, to data sharing, to open platforms of data, to participation. So we get to kind of bring that back now when we look at our own province and offer some of those opportunities across Canada. And I think the ecosystem here is still forming. I think from especially a health perspective, there is benefits to having large health organizations who are operational and who are pooling together and combining forces with groups like AMI that are also government funded. There are benefits to that in terms of singular large authorities. There are also is a need, I think, in every ecosystem to recognize the diversity of innovation and entrepreneurship that's happening, and to find very direct pathways to engaging to that. I think it's still under construction, I would say, here in Alberta, but we're happy to be a part of it. We are forming relationships. For example, we just launched a hub with the University of Waterloo, ironically, in Eastern Canada. We should be looking at something that's similar here in our hometown.
And I believe we are looking at something similar here in our hometown. So I'm going to go next to Neesh with U of A perspective and AI hub perspective.
Sure. So, I think, my lens is an academic lens, and I really am thinking about universities as an engine for innovation across the ecosystem. And so when we sort of started thinking about the applications of AI in healthcare a few years ago, I think there were kind of three key things that we were thinking about. One is that the application of AI is in health systems, and health systems in general are inherently multidisciplinary. And so to not have that multidisciplinary lens when you're thinking about potential solutions or applications would be a major miss. So when we had created the AI Health Hub at the university, the intention was to bring together people from business, law, philosophy, ethics, engineering, medicine, nursing, and a variety of other health disciplines to really think about these problems collectively, and also think about what the implications of applying these technologies are for workforce, for workflow, how relationships between providers and patients change, how relationships between providers and health systems change. So to think about all of those things at the outset. I think the second thing is that I think we see across the board, not just in healthcare, that where the promise of AI has not really materialized is the fact that many times a solution is proposed at looking for the problem. You're not thinking about it. A solution is provided, and then there is an expectation to implement it without thinking about these things from the ground up. I think the university and really one of the things that we've developed to sort of respond to that is a living lab. And we can talk about that a little bit more later, but really the idea is that solutions should come from the workforce and the people that are in it, and that they should be designed to address specific problems as opposed to trying to apply technology into a system that it was not developed in. I guess the third part of that is in order to do any of this well, you have to have access to data. And so sort of the third platform that from the university perspective is really improving data access and having curated data assets that allow us to do this work. And so in doing that, we've kind of created something called the Trusted Research Environment, which is really leveraging investments from the provincial and federal governments to create a data platform that allows researchers to go in and look at the data. So a great example of that is the work that Carrie is doing with one of the CFAR fellows. So that was something that Joey talked about before. So data platform.
Will you define for the audience what CFAR is? I know some of us are very familiar and some won't be.
So yeah, I mean, maybe Joey wants to tackle that a bit more, but this is a federal government investment program that's really investing in academic work related to artificial intelligence. It's a national program and is very much championed by the AI institutes across the country. So that's Amy in Alberta, and Vector in Mila. So it really has propelled the advancement of AI research and innovation across the country.
And I'm going to give it to Joey to say a little bit more about that investment if he wants to, and then we're going to key off what you said about solving problems in the system to go to Paula after that.
Yeah, I mean, just to add to what Neesh said, so the federal government gives sums of money to, so Amy's one, Vector and Mila, to go on the search for these for great researchers. They're to bring them to Canada, set them up well, and help solve problems in Canada, but also help keep talent in the province. As everyone knows, there's a lot of great talent going to the United States because of the financial benefits, but also just their environment in general is a little bit more attractive to some researchers. So the federal government, as a response, is trying just to keep all of them here through the CFAR program. So you can kind of see a lot of CFAR chairs sit at Amy, but also at the other institutions, and that's just part of that initiative. And I'd say that's one big thing about this Alberta Advantage is just that the support for programs like this, and just to support building this AI environment. They're just trying to be more attractive, as we saw with the recent Meta announcement and all the other announcements that are recently coming out with the AI initiative. Really great things happening.
And CFAR is an acronym for...
Oh man, you're testing me now. Yeah.
Institute for Advanced Research.
That is it. Yeah.
Okay. And so then to Paula, talking about problems in the system that we are solving rather than having a solution and then looking for a problem. Because I really think some of your newer innovative thinking in this space in partnership with Alta ML has been really geared in that direction.
Yeah. So I started out by telling you about the almost doubling in numbers of new cancer cases in the province, which is similar to everywhere else. So I don't want anybody to go away and go, oh my God, there's something wrong with Alberta. It's just the way that the numbers are showing up. That puts pressure on the system. So we have more people who need more services. And I'll tell a little story and then I'll answer the question if that's okay. So several years ago, anybody diagnosed with a stage 2 non-small cell lung cancer would have had surgery, chemo. They might have seen an oncologist 3 or 4 times and sent on their way, hopefully. These days, we do molecular testing. So we test the tumor for different genetic characteristics. And it turns out that if we know more about the tumor and its genetic characteristics, we can tailor the treatment to that person's tumor, increasing the likelihood of them being able to respond to treatment. So, which is fantastic. But the thing is, if we send people for this new immunotherapy where we're harnessing the immune system to tackle the cancer, all of a sudden, rather than seeing your oncologist 3 or 4 times, you're now seeing your oncologist 25 times, right? So that's one disease, one stage of cancer, one impact. So it's not just more people that are coming, but it's more complex treatment. It's giving people the opportunity to live longer with a better quality of life, which is all that we need to be doing. But it puts a stress on the system. So the ways that we deliver cancer care, as I said, today are different than 10 years ago. We have new indications, we have new treatments. I would say in this province, we are incredibly fortunate that this provincial government sees that. We've just had a new strategic plan for cancer released by the government of Alberta. We have investments in AI. And in cancer care, we have invested quite heavily in making sure that all of those interactions that people have with the system can be translated into data that we can use. So about 3 or 4 years ago, we looked at all the data. And in the past, very funny, because you're talking to people and they go, yeah, no, that's too complicated. No, you can't make that assumption with that. And they get you down to, well, in my clinic, this is what happens. You're kind of like, well, that's no good from a systems perspective. So how do we harness the heterogeneity of the data we have to look at this from a systems point of view? So we thought machine learning, subset of AI, would be the way to go. And we have really smart epidemiologists, really smart clinicians, but we didn't have expertise in machine learning or AI. Through, again, provincial government funding, they had a thing called GovLab AI, which was an investment into linking up public sector with private partners to accelerate their ability to do machine learning or AI. So we were able to take advantage of that and hooked up with a company here in Alberta called AltaML, who really accelerated us up in terms of capacity, skills, and expertise to start to address our systems pressures, access, wait times. How do we design the systems more effectively, and how do we predict what's coming in the future? So those are our big things at the moment. But as we've now developed this platform, we've developed this skill set, we can now see that there's interest coming from pharma saying, oh, you guys have a sandbox where we could actually start predicting what would happen if this proportion of people were moved on to that kind of drug. So we're starting to see the potential grow and actual real problems, systems issues, and putting AI and machine learning to work to tackle those. Thanks.
Yeah, and I just have to tell the audience, I've been briefed on that in some detail, and it is extremely cool and really, really awesome use of our data. Glen, kind of dovetailing off of that and this conversation about implementation in the system and successful implementation, you've shared before some interesting observations on how future AI applications are going to have to relate to clinical workflow. And yeah, I was wondering if you'd speak to that in this context.
Yeah, I think that, well, it's a couple things, and just to repeat, I think it's already been said, starting with the problem. I often, we get a lot of vendors coming with solutions. So start really having a clinical champion. So there's a pull, looking to address a problem. And then, the other thing that's really critical is the intent, I think, of AI solutions is to reduce friction, especially for, the clinicians working the system. So anything that we implement needs to be embedded in their workflow. So you can imagine in your own life, if you have to go and log into a separate application, do something else, the likelihood of strong adoption is probably pretty low. So it's really important, to find solutions that can be embedded at the point of decision. So when clinicians are making decision, within their system of record that they're using, within their existing workflow, that really helps reduce the friction and I think ensures higher success of adoption and scale. Again, there's probably lots of examples of really great AI solutions that have been sort of left behind just because they just did not fit well into the workflow.
Awesome. And then, yeah, continuing on that system perspective and adoption, Myrna, you have the ultimate systems perspective, kind of. So I was wondering, what thoughts has the conversation to this point prompted for you? And what would you say about that system perspective?
I think, again, AI is really, has taken hold and needs to take hold in a variety of different levels or spheres in a system. So you were talking about cancer care, actually pharma getting involved now and looking at it from a systems level, from an investment level. We spend a lot of time in my company down to the individual and looking at how they exist in their community, in their household, in their universe, in their access to care, in what are the barriers, what are the opportunities, how can we target things at an individual level. But we also spend and pull that back up into where should we be paying attention? Is it precision care? Is it remote patient care? Is it how do we connect this? We call them the modifiable risk group. So whether that comes to cancer, or we're doing extensive work in the EU in terms of cardiovascular disease and comorbidities, where is that modifiable middle in our population, and how are we designing systems of prevention, of primary care, of looking at, tips of the iceberg, and yet looking at the rest of the iceberg too, because if you remove one barrier or access to care, where's the pileup going to be? It's going to be, you're going to see your oncologist 25 times instead of 5. So are we ready for that? And if we are ready, what does that mean? If we aren't ready, what do we have to do? So those are the kind of the system level design areas that we function at, and we apply artificial intelligence that, like I say, takes that holistic individual perspective, but also, not only just solves problems that are today, but that we can see, tomorrow, we can see under catastrophic events, security events, polycrisis in healthcare is one of the latest ones that has landed in our company. But also, those ones 10 years, 20 years, when we are looking at anticipated health shifts and changes in the population, when we're looking at anticipated therapeutics or system access or design, how do we get ahead of that with our investments and our policy as well?
Yeah, and certainly we see across industries, and especially across creative media, a lot of criticism for the use of AI because, there's humans who want to do that work. But in healthcare, I think we all sitting with this demographic shift that Paula characterized through the lens of cancer care, but that, is commensurate with the aging population in general across all healthcare channels. Like it's not about taking jobs, but like stretching the resources and making the most of what we've got, because there is so much demand that we won't get beyond it with current ways of doing things, right?
Our work in the EU was sponsored out of a whole bunch of nations coming together saying, we can't build hospitals fast enough, we can't staff them fast enough. What are we going to do? And so that was the impetus of the big consortium that we're a part of, was the recognition that we've hit certain constraints and we need to invest differently, and we need to understand strategically how we invest.
Yeah, and certainly we've seen like increases in throughput in healthcare services that are well validated in domains like radiology, where the number of images that can be worked through in a given time period has gone up. And so there's some evidence there that's promising for future additional applications. But now changing gears a little bit to think instead of about what makes things successful, what could instead represent some problems. And I certainly know, I've had family members that have said things, referencing my example in the radiology space. I want a human to look at my films. I don't want an AI to look at it. Whereas I'm like, no, give me the machine. I'm really interested in everyone's perspective on what makes things safe, trustworthy, worthy of public confidence. And I think on this one, we'll start with Glen, because you shared some thoughts in the lead up to this panel on governance.
I think that's, yeah, very important, probably especially important in healthcare. I think, yeah, again, I don't have in-depth knowledge of all the industries out there that are leveraging AI, but it's certainly healthcare, like the legislation, the concerns about hallucinations, is it impacting clinician decisions? And so, what we've done, I can speak to what we've done certainly in our environment, is we sort of look at AI and try and apply a tiered-based risk model. So if you think about even your personal productivity, like using Microsoft Copilot or something for your personal work, pretty low risk. We make sure that we, from a data perspective, that we have tools that are, we know where the data is going. It's safe. It's within our environment. So we're not asking employees to go out to open models. They're keeping sort of our corporate data within our environment. So, but again, generally pretty low risk. And then on the other side of that scale, there might be higher risk AI applications, where it's potentially influencing clinical decisions, patients are interacting with it, in which case you need different types of controls, different types of validation, probably ongoing validation, because the models are changing. This is the other challenge we have with AI. It's not like we implement it and it stays, static for the lifetime of that application. As new models are introduced, the results can change. So again, there's a whole other consideration around controls need to be put in place to make sure that you understand how the decisions are being made. There's always humans in the loop, again, for I think decision making and things where there's any kind of risk. So lots of different considerations, but again, I think it goes back to like really tiering the risk so that there's the appropriate controls in place based on the risk.
Yeah, that's fantastic. And there's other industries outside of healthcare where human in the loop is a very old conversation on automation. Some folks know this. I started my career in aviation economics, not healthcare economics, and certainly going back to tools for air traffic controllers, a high safety environment. It's a well-worn concept to some extent with human factors engineers. Joey, do you want to add anything to that about responsible AI frameworks?
Yeah, so for Amy, we follow this responsible AI framework for all our client projects. So there's essentially a checklist that we'd go through for every project before we'd even start to make sure they're responsibly using AI. And a lot of the questions in there are things around, is there a human in the loop when you're going to deploy this type of system? What kind of decisions are being made? Like how is a person or individual being impacted, society and whatnot. And essentially, it just helps. It's another way of categorizing, developing these AI models, because there's just so many things that are changing and happening that trying to create something is really difficult. And this is kind of the framework we follow, and we've been following for the last few years. But likely it will change in the future, and we'll kind of see where it goes.
Yeah, excellent. And Myrna, did you want to say something about the need for transparency and supporting informed debate under uncertainty? Because I think, you have thoughts there.
Yeah, so we often do a lot of modeling into the future to help people make some billion-dollar decisions, and there has to be absolute certainty. So we practice what we call glass box AI, so where everything is highly explainable. There's lots of humans in the loop. There needs to be for the level of confidence that we need to be able to provide. And I think, having that ability to look at a future where we aren't in the business of prediction, we are in the business of the imaginable and unimaginable, and that sandboxing of a variety of different forecasts. So we're forecast agnostic. People need to be able to, bring in those opposing sometimes forecasts. We did work in Los Angeles where they couldn't even agree if Los Angeles was going to be growing or shrinking. And so, and this was for critical infrastructure. So, it's being able to invite those forecasts in to explicitly include those forecasts and be able to look at whether or not it even makes a difference. I think those are things that, we need to be highly adept and conversant in, because, the answer isn't always 72.67. We need to be robust inside of some very dynamic futures.
Yeah, and so that's awesome. And that LA example is really, I would love to talk more about that at the break. And so I think next, Paula, I'm interested in what you'd have to say on co-design in the space, or whatever else you want to say. And then likewise, Neesh, after Paula, role of the living lab on kind of trust and responsible use as well.
Yeah. Okay, I don't have any more stories to tell. So I think I just want to pick up on the responsible AI stuff, though. And I think this was a big learning for us as we got into this space. So you talked about explainable AI, and that is very much a mantra that we work with. But the learning for us was that we started trying to triangulate data scientists and machine learning people with epidemiologists and clinicians. Maybe it wasn't even quadrillate because we had a clinical operations people in there. And that was a very eye-opening experience, because it turns out that a lot of people who were coming from outside with really good machine learning IT experience were used to working in 2-week sprint models. Okay, right, we're there. And our epidemiologists and clinicians were then looking at this going, no, there's something not right. And the reason to have epidemiologists is because you really need to be starting to look at bias. You need to look at population structures. You need to look at changes over time. And those people are expert in that. And then our clinicians obviously come with their like, you might think that, but no, because. So really slowing it all down, learning to talk each other's language, because it turns out they use different words to mean the same thing. And having the patience to nurture those trusting relationships and build a table where each person around that table brings their skills, brings their expertise, but they all put something into the potluck that really makes a party. And that is a really, really important learning for us, because it's so easy to suggest that in a very complex healthcare environment, in a very complex and rapidly shifting environment, that you can apply AI models. And back to Glen's point, they might be okay today, but they might not be okay next year or the year after that. So it's always being thoughtful, and it's bringing that rigor. And I will say one more thing about this province, in that we are fortunate to have been able to attract highly trained people into this space in healthcare. So thanks to U of A, thanks to the people who are training the next generation, who are willing to come and bring their skills to the table. Now, you asked me a question and I've waffled on. So what is
Co-design.
Co-design, yeah. Actually, I was getting there. There we go. Co-design. Co-design, super important. So when we started out, so we said, we're going to tackle this. We're going to get into this space. What we did was we went to the leadership of cancer care in Alberta and said, what keeps you up at night? What worries you? Access, wait times, people needing to see an oncologist sooner than we can get them in. Okay, so we build a project around that. So we work with our tumor teams. So our tumor teams are people within the system who are multidisciplinary teams, and started working on what we call patient complexity. To try and understand how patient complexity leads into time in care and workload and workforce and all those kinds of things. All of that needs co-design, because we know, our team knows the math, it knows how to do the stuff, it doesn't understand how clinical care works, but they have built excellent relationships with both our clinical operations teams and our clinicians. So co-design is really, really important in defining the problem and refining the solution. And that's all I need to say on that. Thank you.
Excellent. Neesh, Living Lab?
Sure. I mean, I also just have a clinician's perspective.
Absolutely, go for it.
So untrustable AI, because and honestly, my thinking on this is shifting as AI is evolving. And in fact, I was struck by a comment that was made by one of my colleagues in Ontario, Mohammed Mamdani, who was talking about the fact that from a clinician perspective, explainable AI is probably less important than people actually think it is. And the reason for that is that people just trust things that work. And so, 3 years ago, AI models were, maybe performing 50, 60% as well as humans. Now they're performing almost equivalently, and we are expecting within the next year or two that they will be performing better than humans. So in that situation, how do you evaluate how to use these AI models? So there are a couple of papers that came out in the last couple of months that evaluated, like, for example, ChatGPT medical AI models against people, clinicians, and found them to perform equivalently. So, I think we are kind of heading into a new frontier. And from a university perspective, we need to understand that human-computer interface. We need to understand how humans interact with computers, when things can be trusted, when maybe the computers are right and humans are wrong, because that is happening increasingly frequently. So I think that is a whole new area of study. So this idea of the human in the loop may change. The human's role in the loop may change over time. So that's something I think that is an area that's ripe for study, and I think will be a focus in the next 5 years. Now, in terms of the living lab, so this really gets back to what Paula was talking about. So, in order for solutions, I mean, I think, people have been speaking about implementation and the importance of implementation and having input from the people that are using the AI as well as the people that are receiving the output of AI, to have their input when you're co-designing or when you're developing a solution to a problem. And so essentially the Living Lab is something that we have started at the University of Alberta. And this is really a collaboration with the health system to be able to co-design together so that problems are presented from frontline clinicians. They are, whether a determination is made as to whether they, set or sort of address health system priorities, and then solutions are co-designed so that they fit into the workflow of the people that will be eventually using that solution. And that really is, I think, the model going forward. I think developing these types of solutions independently of seeking the input of the systems in which they will live will not get us any further. So I think that is the model that we are hoping to continue and expand.
And that was certainly the spirit of the title of this panel in its full form, which was Intelligent Use of Artificial Intelligence in Health, which was not, we're doing the AI for AI's sake to be able to say to our bosses, we're doing the AI, but it's where we're actually investing to get something out of it with purpose. And so for folks who see me fiddling with my phone, I'm not up here like asking Claude to come up with the next question or something. I have wonderful questions from the audience in the app. And one of them kind of parlays nicely into this that we've just been talking about trust, and noting that the folks who make up our audience for this session are leaders in their communities, and asking over the next year, what could they do to reduce fear, build trust, and encourage responsible adoption? Anyone who wants a shot at that?
I think that there is a lot of messaging out there that's quite concerning and confounding. Attending Penware and talking about energy and water futures and economics and data centers and surveillance data, and I think that building trust and community for us has been really leaders taking unique and transparent and data-informed steps towards saying this is why we are doing what we are doing, this is how we are doing what we are doing, this is the opportunity of utilizing artificial intelligence in this way. These are the problems with using artificial intelligence in this way. I think in being very open as leaders about those steps that are being taken and the whys behind them. We deal with a lot of leaders who are very concerned about the populations and the data that doesn't exist in any form to be utilized by artificial intelligence. And I think that's just as important as a conversation in communities. Also, the people in community, whether it's the clinicians or whether it's the patients, who have information in a form that is not captured in a record or a diagnostic point, to be able to figure out ways in which those conversations can be widened, and those perspectives, the elder knowledge, the knowledge that you have. If you're a woman, our data is particularly deficient in healthcare systems, and being able to ensure that the systems we are building, the parts that are advantageous about them, but also the parts where we need to invest and do a lot of work to ensure that First Nations populations in Canada, for example, have a unique capability to be able to add their voice and their information in a way that's reciprocal, they can receive benefit from. So I think being open about what the issues are and confronting those with a space and an energy and a room to do so is really important.
Yeah, does anyone else want to follow up on that, in particular on bias and equity?
I will. Thanks for the question. It's really important. Currently, the conversation around data centers seems to be focused on electricity, water, resource use, and I'm not sure that we're hearing the stories about the potential benefits and the uses and the questions that can be answered that potentially could not be answered in other ways, and what the benefits to Albertans, Canadians, people will be. And I think that's something that, you know, we need to start thinking about how those stories could get told better. In terms of equity, you mentioned Indigenous populations. We also have other equity-seeking populations around within the province who we actually don't have a lot of data about. In contrast to the US, most Canadian health systems do not capture data on race or ethnicity. We don't have identifiers, which is typically the way that is described. So a lot of these communities will tell you stories, and again, I'm coming at it from a cancer perspective, about late stage diagnosis. They feel they're getting diagnosed with later stage cancers, which are harder to treat and which are associated with greater mortality. They'll also tell you that it's difficult for them to complete treatment, either because they're traveling a long distance for treatment or there are other things happening. We have no way of corroborating those stories from community with the data we have. And if you think about it, and you think about, you know, the stories that are being told and the stories that those communities know to be true, but from our Western colonial perspective, as some would have it, we don't have the data to be able to back that up. So, you know, it's something that we need to think more carefully about in terms of trying to understand where there are inequities in treatment, where there are inequities in diagnosis, and starting to fill those gaps. And if that's a data-driven story, so be it. But if it's another way of, if there are other ways of doing it, so be it. My perspective.
Maybe just one more thing to add, just about in terms of equity. One of the things that we've been working on with government is, you know, we call the digital front door. These are, you know, ways for Albertans or patients to interact with the healthcare system digitally through digital channels. And increasingly, I think we're going to start seeing more like AI, you know, navigation or AI, intelligent navigation built into these systems, so that it helps, you know, again, Albertans or patients navigate to the most appropriate care. That, of course, does create some inequity for, you know, you think about think about my elderly mom, because there's no way she's going to be pulling up her cell phone to try and interact with the healthcare system through her phone. There's those that don't even have the technology. And so I think, again, the flip side is, it's great for those who have the technology, who are competent in using the technology to, take advantage of that digital channel. But again, I think it's going to create even more inequity to some populations that just won't use that channel.
Yeah, I was just going to also just to add to that, I think, AI literacy is still a huge issue, and that's not just amongst the general population, that's also amongst healthcare providers. And I think that is a huge an issue to tackle, both in, in the training of our future healthcare providers, as well as the existing healthcare provider population. So I think that is part of the solution, is to be able to provide a better understanding amongst those populations of what artificial intelligence is and how it can be incorporated into clinical practice. I think obviously bringing the general public along is incredibly important along that journey. And I think part of that is having great clarity of purpose. What is the data going to be used for? How will this help? And also provide demonstrable evidence that doing these, applying artificial intelligence actually improves healthcare outcomes. And that is not something that there's a lot of data to support right now, to be honest. There are half a dozen trials. This is not something that has been, it may improve efficiency of healthcare delivery, but very, very few studies have shown that AI actually improves health outcomes for people. Part of that is related to the access to data in equity deserving groups. There are many reasons for that. Also part of that is just the rapid pace of change, and clinical trials and the ability of our conventional methods of assessment have been slow to catch up to the evolution in AI. So those are all issues to think about.
Yeah, thank you for that, all of you. And just kind of going a little step further on that, I already mentioned aviation in this context, and folks who've seen me on panels before know I can pull from other industries, and apparently I'm in an aviation mindset this morning. And there is a lot that's been written on how aviation safety culture has influenced development of hospital safety culture over the decades. But it's tweaking for me right now. The practice of medicine has, and we've all experienced this, a robust practice of informed consent. And I'm wondering if the broader field has lessons for that in how people are asked to offer up their data for different applications. If anyone wants to take that. I knew Myrna would be brave. She'll answer any question that I ask.
Oh, I've answered so many questions. So we, again, my company is actually a certified Indigenous business as well. So come from a profound respect and sensitivity in relationship with First Nations, have understood a lot of the trauma and in past experience of sharing data or having data created around their populations. So we're actually engaged in some really unique initiatives where we stitch together fragmented data that's been collected by other organizations to rematriate data that then those First Nations can use in reciprocal ways, and they can offer that for participation in other programs. But I think that idea of informed consent is really important to build that trust and that relationship. We've seen it around the world in operation in Taiwan, where we're also active. You have the phenomenal ability on your phone to be able to opt in, opt out at any point, send your information to various research projects that are meaningful to you, your family. Do it for a month, do it for a day, say, no, I don't agree, I want my data back. And it's very transparent and it's very well managed. And I think that's something that looking around to other systems and how they manage that, even that digital access, is really something that we should all be looking at for best practice, and all be inviting that conversation about the things that we find about different ways of doing that around the world.
Yeah, thank you for that, Myrna. And I'm going to throw it to Joey now because I think he wants to respond to
Yeah,
something you want to
yes.
say.
Yeah.
But I also want to ask, like, coming around to that regulatory environment as well after your initial thoughts.
Yeah, like in initial, like we kind of dealt with this problem a bit at Amy. So this consent topic, a lot of the times because artificial intelligence, this topic is so new, when you're providing consent for data to train a model or whatnot, I think that whole sentence there, a lot of people don't understand what that actually means, what data is going to them, like how is it going to be used, and I think it's just part of because the technology is so new and it just hasn't been talked about. Like right now, what we've heard is everyone right now is just talking very negatively about AI in terms of just, hey, it's going to displace my job. I'm going to lose my job. For a number of years, we've heard kind of this narrative of it's going to replace certain clinicians, and there's just this narrative that I think overshadows all the great stuff as AI has done. But it's just really hard to climb out of that narrative right now, and that's the same thing with consent. I think everyone just has a negative view on, oh, you're going to use my data for to help you benefit financially. Like, why do I want to do that? And it's just helping people get educated, that whole AI literacy bit. And in terms of the regulatory bit on our end, governments are as well want to implement AI into the health system, but a lot of the regulations and legislation is it's just hard to work with because they weren't ready for AI when they're creating these legislations. So a lot of work is being done to change it, but it's going to take time and some more discussions.
Thank you. And so I want to go to one final question before we go to the audience. We've mentioned the word resiliency a few times across the panel, even though I think the majority of our conversation has been more in efficiency. And certainly I've used the term throughput already today. But I wonder before we pivot to questions, if folks would offer thoughts on that resiliency piece, perhaps also reflecting on recent experience of like a real test to our health care system in the form of the COVID-19 pandemic. But then likewise, we've had shortages of key supplies and materials and medications over the remaining years since then. And yeah, and maybe in this weave a little bit of a sense of what is your definition of resiliency in this context? If anyone's willing to go first and bite on any of those topics. I knew Paula would be good for this one.
You didn't really. It's a super interesting question. And again, I only speak from a cancer perspective because that's really all I know. But I would say that our cancer system has been incredibly resilient over the years. It's a system that generally makes things work. Although we're starting to see it creak at the seams a little bit. I did mention earlier the government strategy, 10 years, transforming our future, Alberta's cancer plan to 2036. And actually one of the strategic goals in there is building a smarter, stronger, more sustainable cancer system. So it really does speak to that resiliency. And actually within that strategic goal, there is an objective related to AI, machine learning, and how we harness data more effectively to predict the future, to forecast where we might be going, to forecast what the impacts might be. So again, starting to be more evidence informed, perhaps, rather than licking a finger and sticking it up in the wind. Really starting to get a little bit smarter about projecting where we might be in the future, and then how we plan to sustain that as we go. I don't know if that answers the question, but I think I
think it does.
There.
I mean, I think there's no singular answer. I think
know.
that was really helpful. And, it also kind of popped into my mind, like my own definition of resiliency is one I define in a contrast of like the opposite of brittle, and so thinking about where things can like flex and adapt versus where things break. And certainly like the tools that support resiliency will have to themselves be resilient.
Yeah, and I mean it's super interesting as we go, and this is not meant to be a political statement in any shape or form, so please don't interpret it this way. But I'm sitting here in Edmonton with Across Cancer Institute, which is our tertiary cancer center, which is about 60 years old. And it flexes and adapts and it makes it work. And what most people who enter the doors there will tell you is that they continue to receive excellent care. They feel like they're looked after. They get the treatment they need. And we are also a very research intensive institution. So people get offered clinical trials. They get offered opportunities to participate in research, and getting that hope of perhaps a longer life, a better quality of life. Again, because we integrate research with clinical practice every day. And that, I think, feeds into the resiliency mindset as well, because we're not stuck in same old, same old.
I see Neesh nodding, so I'm going to pick on you a little bit. And like, how is your work with the hub like promoting this kind of thinking around? You used the phrase in the pregame, healthcare 2.0. I'm just really interested in your thoughts there.
I think, given the fact that we will not be able to manufacture twice as many physicians in the next 10 years, which is probably what we need. We need to look to other solutions. And I think, AI does give the promise of both sort of extending the scope of work of non-physicians into the healthcare space, and providing sort of an upskilling and providing expertise and in places that maybe more broadly. And I think that is certainly the great promise of AI from my perspective in terms of maintaining resiliency. I mean, I think as Paula said, I think the COVID-19 pandemic was a really good example of health system resiliency in the province, in that, there was low leveling done amongst the acute care hospitals. There was real-time monitoring of who was coming in, what the bed capacities were everywhere, and how to distribute the work efficiently. And so again, AI does hold the promise of continuing to knit together the system to allow it to bend and flex to whatever challenges that may come, which at this time, are workforce related largely. Yeah.
Excellent. Anyone else before we go to the audience?
So we spend a lot of time not in the what if, but the what. I call it disasters or us. So when people create systems that they want to sandbox in our synthetic models, we run those forward, but then we also intervene. So while we're doing work in Europe with remote patient care, we're also interrupting critical infrastructure to see what happens when your communication systems go down, and you've got patients distributed who are being remotely monitored in your communities. So I think it's really important that we begin to test our ideas of resilience, and put those systems, as we build them, see how adaptable they are under all different kinds of conditions. And also we do more and more work now in defense. So investing in primary care that's in communities. We're involved with a group that is creating ambulances and ambulance capabilities out of personal automobiles in different countries, because they can't possibly rely on a system where they have to send healthcare out and have it come back. So they're distributing that resilience amongst populations and testing out what those investments look like, and the potential impact of those investments, and the really, really fundamental importance of beginning to invest in primary and prevention, because it's seen as a matter of national security now how healthy your population is and how they can manage themselves where they are and not end up at acute care. Because there just won't be the capacity there. So I think that's part of how we need to look at this future and understand resilience as well.
Excellent. Yeah, and just to dovetail off that, all of that is super relevant in province to conversations about rural healthcare, but also around the world about rural healthcare. We had a speaker from the OECD at our recent rural healthcare conference talking about healthy aging and how the difference between healthy aging scenarios strain on healthcare capacity versus absence of healthy aging is profound. And that presentation is on the events page of our website if anyone wants to follow up and watch that. It was really excellent. And so going to the audience, I don't know if we have a mic in the room. We do have a mic in the room. Excellent. Does anyone have anything they would like to ask our panelists in general or a specific panel member? Also happy for you to put questions in the app. I'm trying to keep an eye on that, as I had said. Do I see any hands? So I had a colleague at MIT that would leave a full 3 minutes of awkward silence to prompt the thinking on questions. I won't make you suffer that because I certainly do have extra questions for the audience. So put your thinking caps on if you have something. We'll do a little bit of a lightning round while you think about that. And I guess what I would say to start with lightning round, and we'll just start with Joey and go down the line back towards me and say, if this audience remembers just one thing from today's session, what do you hope it is?
I think we talked about it a lot, but like work with clinicians if you're going to be in the space, because figuring out a problem together is going to be a lot stronger than coming up with a solution and trying to find a problem for it.
He stole mine, but
oh dang,
it's okay. The other thing is, we often have really good success with small pilots, but then we need investment to scale. So I think thinking about how we scale, both from a change management, from a funding, like that's always often I think where things get stalled out is how do you move it from successful pilot to scale, and often it's sort of just do we have the funding, the support to do that.
Critical for any innovation.
I think one thing that I'd like this audience to remember is that we don't have to wait for the data. So there are ways in which we can step forward into modeling futures, scenarios, therapeutics, health, populations that don't exist today, so that we can get on with understanding what we should be investing in and informing the choices that we're making today. That we've been stuck in for a very long time in waiting for the data. And there are incredible advancements now that enable us to just keep moving.
Paula?
Yeah. I'm going to get my soapbox out here and stand on that. We don't have to wait for the data, but we also have to invest in making good data and making it available. It's not magical. It's magical thinking to think that AI, machine learning, is going to solve all our problems if we don't invest in the boring, tedious work of actually making a really solid health data infrastructure that's linked, accessible, and useful.
I strongly echo your comments, but I would also I would use the word agility. I think governments, health systems, universities are not generally fast to move or act or react about anything. So I think given the rapid pace of change, I think we all of those institutions at every level really need to think about how to be more nimble about pursuing some of these opportunities and developing solutions.
Awesome. And thank you all so much for that. And appreciate that between Myrna's comment and then subsequent comments. Like, it's not all or nothing, all one or the other. We can be saying there are places where we can go fast, but also at the same time be investing in capacity significantly rather than making wishes. Throwing it to the audience. Were there any hands to go up? Okay. Oh, go ahead.
They present the case to other doctors and get opinions from a board is what I've heard of how to treat that case. That seems like something AI could be the board potentially, and it could be faster and more information could come back. Is that something where it's being used right now?
Yeah, I mean, I agree. I think I think there was a study that came out of Harvard last month, and so they were again sort of comparing a single physician's or a group of physicians' impressions to an AI impression, and then looking at performance. And I absolutely do think that will happen. That in fact, the question will be how to incorporate and how to interpret the data that comes from that AI board, but you are absolutely 100%. And there actually are simulations now of boards where each member of the board is an AI agent providing input. So they're already doing work like this, for example, in transplant assessments, things like that. That work is happening, and I anticipate that it will continue to evolve.
So one more question from the audience.
Hi guys, thanks for being here today. I just have a quick question on the job impacts that you think AI will have in the medical sector. You hear a lot of things on the internet and popular discourse about how it's going to destroy a lot of jobs. Do you think in the medical field it will add jobs, reduce jobs, have no net effect? What do you think the overall impact will be? Thanks.
Yeah, I mean, I think it will change jobs. I don't know that it'll actually, I think there are a lot of issues that have yet to have to be dealt with in the medical sector. I think training of physicians and all healthcare professionals is going to change as AI becomes increasingly adopted into clinical decision making. I do think there are some areas that will be more affected by others, but I don't think that they will necessarily be. I don't think there will be job losses. I think job descriptions will change. I think clinicians will play a different role in the health system than they currently do. And part of that is just providing the humanity of care. So that is not something an AI can do. They can help you with decision making. They're not at the bedside holding hands or in the clinic and talking to you about your health information and helping you plan a strategy. So.
Yeah, I'll just add to that. I think in the oncology world, again, oncologists we've been very successful actually in recruiting more oncologists lately into Alberta. They see it as a good place to be, but they're in short supply across the world. And when we talk about sort of job losses or job additions, Neesh has talked about decision support. So it's more about how do we best use the skills of the oncologist, and how do we perhaps think about task shifting some of the things that you don't need an oncologist to do that could be supported by AI. So, again, as we talk about developing and implementing new models of care to set us up for the future, I can't predict job losses, but I think we will see task shifting in some places. But that's all.
You good, Glen, or did you have one more thought?
I'm good.
Okay, and so with that, we have time. I thank you all so much for attending this morning, and we're happy to answer any further questions or chit chat at the break. Thank you.